Good afternoon, everyone, and welcome to this online forum entitled Undue Caution or Reasonable Precaution, Living with COVID-19. This is jointly hosted by the Medical City and the Philippine Daily Inquirer, with Inquirer.net as our streaming partner. My name is Gideon Lasco, a doctor, medical anthropologist, and Philippine Daily Inquirer columnist. I will serve as your moderator for this forum. Most of us have far more questions than answers when it comes to the pandemic, and the same can be said of the data being reported by the DOH or the policies being announced by the government. In this forum, we hope to contribute to answers by sharing experiences from the Medical City, a hospital that has been intimately involved with the management of COVID-19, as well as from resource persons from various fields, from business and hospital administration to the clinical and social sciences. Hopefully, this conversation will help us get a better handle of how to cope with COVID-19. And we're really happy that you are joining us this afternoon. We will have an open forum after all the speakers have presented, so please feel free to start asking your questions in the comment section. Leading off our four speakers is Mr. Jose Javier Eki Gonzalez, the chairman of the Medical City. A magna cum laude graduate of the University of the Philippines, Eki spent some time in the US as a banker after finishing his MBA at Harvard. Returning to the Philippines, he handled finance for the Lopez Group and eventually bought RCPI from them. He transformed RCPI into USSC, a leading money remittance agency and the country's largest agent of Western Union. Eki's unique position of running a business and heading the board of the hospital of the Medical City gives him a perspective that we can also learn from today as he talks to us about prescriptions for business adjusting to a COVID economy. Let's now hear from Mr. Eki.
Thank you, Gideon. For this presentation, I'd like to thank my colleagues from the Medical City, Dr. Jean Ramos, our president, Trixie Chang, our head of our Cancer Institute, and Dr. Michael Tan, our independent director. So let me begin with the presentation. Also, our data analytics and firm, an AI firm on neural mechanics. So I'd like to start off with a picture of a fallen tree somewhere in our village, indicating the state of our economy. Healing the sick would be an appropriate title. The issues I will address are first, social distance, manifest in this question about masks, and then what's going on now in terms of the three T's, which are the biggest concern about the IATF, which is test, trace, and treat. And the key questions to answer are, do we respect social distance? Can we catch the infected? Can we heal the sick? Enough so that we can open up our economy. Did we do the right thing by still clamping down on the Metro Manila area and moving another 2 weeks out? So my first picture is about masks. And of course, the big unmasked man is the President of the United States, who refuses to wear a mask in the White House. The evidence on mask is incontrovertible, though. There is a manifest, true correlation between lowered infection and deaths from wearing masks, the most respectful solution for maintaining social distance. So essentially, between mid-March and mid-April, all the economies in the world started locking down in a major way, except that if you look at the bottom of the chart, the face mask policies of Asia, either by mandate or by habit, were instituted very early on, sometime around March, and the face mask policies in Europe were followed much like a month later. In fact, the United States and the UK don't have mask policies. And you can see by the statistics in terms of death per million population, everyone in Southeast Asia is below 10. And if you look at the others, France, for example, is 395. The US is 226. Czechoslovakia which has a mask policy from the beginning, but a no lockdown policy, is at 25. I think the numbers would speak for themselves. These are some slides that you start with a mask and then you try to practice social distance. And a lot of you have seen this slide. And this is the latest, more controversial element of personal hygiene. There are three aspects to protecting ourselves. One is masks, the second is social distancing, and the third is hygiene. This picture actually came out in Facebook recently. Do you want to eat the cake of the guy who blew out the candle? How do coronavirus carriers infect other people? I find it interesting that of late, the studies seem to point out that 15% of infection is asymptotically oriented or fomite driven, meaning you touch a piece of metal. Otherwise, it's usually during the first 5 days, as you can see by the track going up of the pre-symptomatic and the symptomatic individuals who catch COVID-19. Anywhere from 5 days, that's when we get 0 to 5 days, that's when we get the infection. So what do we do to stop it? I don't know if you know this character. This is the guy from Inspector Clouseau, from Peter Sellers, the Pink Panther. He bumbles and he fumbles, but he somehow gets his man. I think we're going to get there with a lot of pain, a lot of fumbling, but we're I would say on the mask side, we're B, except for these violations that I just showed. Here on the testing side, I think we're maybe a C, only because we're playing a lot of catch up. So obviously, the more tests you have, the easier the better, the more cases you'll catch, and that should bring down your infection rate. What is the ideal level of testing that we should have? In Medical City, we started at maybe 2 to 1. Now we're at 10 to 1, 11 to 1. That's where the country is today. How does testing correlate with the control of the coronavirus epidemic? This is something that a study has been done on this. And if you look at the lower left-hand side, it shows the developed countries that have controlled the epidemic with 3% of positives. What this means is for every 3 tests of cases, you have to do for every 3 positive cases of COVID-19, you need 100 tests. If you get to that ratio, you will be safe in terms of tamping down that curve. So on the left-hand side, you have the number of cases per million people, and on the right-hand side, you have the ratio of 33x in terms of cases. And the minute you cross that level by raising the number of tests, then you're relatively safe. This is where the green line, and I'll tell you, goes above the red line. So these are our tests. The green line is Korea. Korea is a big example of how mass testing work. The second is Japan, which is basically at our population level and which we're hitting in terms of number of tests. And we're going to see the impact on cases in terms of tamping down the coronavirus. In the case of South Korea, the peak in terms of the red line was when they found this lady in this church in Daegu, and she infected 800 people. They ramped up their tests in terms of the green line. Okay, they hit a maximum around 10,000 tests, no, 15,000 tests, and they didn't have to go beyond that because they were slowly bringing the cases down, and now it's in single digits. Okay, but this is nothing predetermined. It's not predetermined by an epidemiological curve. You have to be constantly watching the situation. Last Saturday, South Korea opened its bars and clubs, and they immediately got a hit of around 70 tests, 70 positive cases. So they immediately shut them down. It's obvious that in a bar or a club, people take down their masks, they're shouting and screaming over loud music, there's a virus transmission, there's a viral storm, and that's where you get your COVID cases. Taiwan has always been a good example of how mass testing keeps keeps the case levels down. So we're between 10 and 0. Japan, it seems that as of May, we're crossing the line where they've had to implement a bit of a lockdown because they're allowing people to do this on an everyday basis. They also had freedom, a lot of freedom in terms of some of their tourist areas up north. So they said, all right, so we have to do some lockdown to supplement our testing efforts. And so this is coming down. Italy is also coming down. So at the level where green exceeds red, we have massive testing at the level of 3 positive cases per 100. Here's Russia. It goes the other way. And it's a great example of cases versus tests. It's the US. They have a lot of catching up to do. Because all these guys didn't wear face masks, they have to do a lot more testing than they should have. And here's the Philippines. Are we crossing the line where our ratio had historically been closer to easily 4 to 1, 2 to 1, and now it's around 11 to 1. Hopefully, we don't have to go all the way up to 30,000 tests per day. We can go up to maybe 12 to 15,000 tests per day, and the red line can come down. The red line seems to be coming down, but that's also and that's because we're ramping up the number of tests. But we haven't been able to move up as quickly as we want to. As you can see, the line of the Philippines, the green line in terms of when we started testing, the date there is something like April 10. Before that, it seems we didn't pay enough attention to testing. Bully on us, we didn't capture the tests we needed. So we moved up from 300 to 400 tests per day up to early April for March to something like 2,000, and now we're going up to 6,000 tests. Is that enough? Probably not. I think we probably need to increase it to 15,000 tests per day. This is an example of a 1 month period where we were able to get an island in Guam, 180,000 people, down to where we're able to manage the case down to single digits. And that's because, again, we were able to ramp up the number of tests. Now, Guam can be Pateros with 180,000. It can be a small municipality. So we don't have to necessarily think about the whole country in terms of how to manage testing. We can focus on hotspots. We can let the rest of the country run free. Of course, we have to manage our borders. But there are not enough tests. Okay, so we have COVID tests. We have posthumous tests where we get the test results before after somebody dies. Or we have probable or suspects that have not been given the test. That's 2 to 1. That's not enough. And finally, we have all these errors with patient-level data that have come out recently. I want to make one other point. We have a new testing kit, which has a specificity rate, which is false positive rate of 0%, and a sensitivity rate, false negative rate of 9%, or a sensitivity rate of 91%. This is better than any antibody test kit there is today. It's about ready to be rolled out. So let's go into tracing. So the model here is that isolate 60% of your tests quickly and catch 50% of your viruses quickly, isolate them, and catch 50% of the PUMs. Are we there? Looks like Thailand is there. I'll just read it out. So this is today's paper from The Nation. They have only 2 new cases. Both cases came after close contact with previous cases, a 19-year-old woman in Bangkok whose brother-in-law, big sister, and young nephew were infected, and a 51-year-old woman in Naridwat who was a nanny to a 6-year-old child reported to have contracted the virus. Can we get to that level of reporting? The ideal tracking system should have the capability to trace the following: travel-based community transmissions, which happened early in this crisis, non-travel-based community transmissions, and local cluster transmissions. Recently, Singapore had a big breakout. They were able to identify 98% of the cases as attributable to migrant dorms. The remaining 2% were non-attributable. That's a good rate for keeping an economy open. We don't have that data. We should have that data. Last time I looked, we're only able to trace 30% of the data to barangays. So, how do we help out in the tracking process? Facebook and Google have anonymized data. They can help track and map possible COVID outbreaks, and they use application data. They give us multi-layered maps which address density and how people move around. Even Google can tell us that we are the top country in terms of lockdown, in terms of limiting movement. On average, we reduce 50% average mobility across our whole country versus other countries. We have 94% mobile phones, which are smartphones. And we can get all these location data from telcos, all the way down to all the way up the value chain. And what will that do for us? That will give us information on points of light, which other countries are starting to do. Deutsche Telekom has anonymized movement flows and is giving data to the Robert Koch Institute. I don't know if it's an NGO or not, but it will help us get to where we want to be in terms of tracking people and tracking density. The Vodafone Group is providing governments anonymized data sets to help authorities better understand population movements. Taiwan has taken a different approach with a special app and triangulation and a handset with people and even bracelets to make sure that these guys are tracked. Final concept is treating. Treating, where are we today? It looks to me that we have a free capacity of around 40% in our hospital network in Metro Manila and 2/3 free in the provinces. Okay, between handling COVID plus and suspects. And what are we saying about Thailand? If Thailand can tell us how many people are in quarantine facilities and how many beds they are, we should be able to do that too. And we're not able to do that. So I went a little bit overboard my 15 minutes, but at the end of the day, as you can see from the picture of the tree, we have an economy that has been reimagined so it can grow more branches. Thank you.
Thank you, Mr. Eki. Indeed, social distance in practice is challenging, especially in our touchy culture. And comparing our situation with those of other countries definitely expands our insights as to various possibilities and outcomes. Testing is really at the top of people's minds, including whether we're doing enough and what we can do beyond what's being done today. And although getting far less attention than testing, contact tracing is equally important. And I'm glad that you discussed that as well, including existing technologies that we can tap. So hopefully we can have more discussion on the economy later in the open forum. We now move to the next speaker. There's considerable fear of COVID to a point that even those who need medical attention are afraid to go to the hospital to see their doctors. This, of course, results in a situation where we see a lot of sick people getting sicker at home because they're afraid to get the medical treatment needed to make them better. Our next speaker, Dr. Eugenio Jose Ramos, or Dr. Jean, can share his insights and experiences in handling COVID patients, how they have recovered, while also talking about the equally important question of how we can care for non-COVID patients during this time. Dr. Jean has a remarkable talent for managing recoveries. In his first month as CEO, the Medical City got its 5th accreditation from the Joint Commission International, one of the few hospitals in the country to get that distinction. Dr. Jean was named CEO of the Year by Healthcare Asia in 2019 and led the Medical City to record-breaking growth. This afternoon, aside from telling us about how COVID patients can recover, Dr. Jean will also share the steps that the Medical City has taken to ensure that the people can once again see their doctor safely and get home safe and sound. Let's hear from Dr. Jean.
Good afternoon, everyone. It's a pleasure to be here, and I'd like to share with you basically the experience that we have in Medical City. And it has been almost 5 months since we had this, and I think everything that has to be learned about COVID looks like we know a lot about it. Eki definitely knows a lot about it and has been doing a lot of research. But the experience that we have in medical city really required us to go from the very start, understanding the viral transmission of the coronavirus, putting up important precautions and procedures after we have understood the transmission, creation and activation of teams that will handle the patients and making sure that the patients are secure being in medical city. So that would also require us repurposing of our facilities in terms of ingress and egress. The care of our healthcare workers as well in terms of supply security of the PPEs. Then we had to, of course, handle manpower deployment because even before COVID, we had problems with shortage of nurses. Then, of course, the treatment. The treatment of COVID being it's a viral disease and there's really no known cure for it. And so we had to make do with what we have. But over time, as we had daily reviews and debriefing and our own limited experience, everything is almost like a clinical, a material for a clinical research. We have daily debriefing and actually reviews of how we've been doing week after week. Then we identify gaps and breaches in the protocol in medical city. The first one that we had was basically a breach in the protocol because we were not expecting the first case to come to medical city at that time. Data acquisition and analytics is very, very important to us. So everything that's being done in medical city now is going through a pool of data that is being analyzed even as we speak. But the most important thing, I guess, after knowing all the science and dealing with the facilities and all these things, is really managing fear and uncertainty, handling people with different levels of coping mechanisms. No, and the important thing there is the presence and the visibility of leaders. So the important thing here is really when you are dealing with the uncertain, with the unknown, it's important that there is clear communication. So the patient experience is what I'd like to share with you. And here you can see the circles here. Sorry, the circles here, the one in blue are representing the medical city, and the one in white, empty, are actually representing what's happening elsewhere in the Philippines or in the world. As early as 2014, Medical City already formed its epidemic rapid response team because of the fact that we had, of course, our SARS and our H1N1 before. So the team was activated. And December 31, 2019, there was already a report of the clustering of pneumonia cases in Wuhan, China, and apparently this was something that the Department of Health in the Philippines never really took seriously. And so we were still focusing on travel, the history of travel. January 13, the first case of COVID out of China was actually reported in Thailand. And then in January, Medical City started to identify and prepare for a COVID-dedicated area and retrain staff for infection control and strategies and restocking of our PPEs. While we were ready in terms of concepts, we never really anticipated the volume and the amount, the extent that this epidemic was going to really overwhelm us. And so we were taken by surprise. By January 20, we already started screening protocols of all patients, especially those that were coming from abroad. So we had the mechanism in place by January 20. January 30 was the first Philippine case reported, and this was the woman from China. And then February 1, there was already a first death in the Philippines, the boyfriend of the woman who was the first case. By February 3, the ERRT decided to do an annual mock drill for global communicable disease and a meeting of the ERRT team, which now involved operations, medical, marketing, and so on and so forth. February 5, we started a communication with the mayor's office, the office of Mayor Vico Soto of Pasig. And March 6, this was the first case that we had an admission of pneumonia, and this was a breach because we never expected it. And the patient came with fever, and the patient went straight to the admitting section and was admitted. And so the patient eventually, after about 3 hours of admission, was swabbed because we thought that this might be possible COVID. But at this point, there was already transmission. By March 8th, the first medical city confirmed case was TMC patient 9. No? It was patient number 9. So what we had is patient number 9, patient 9 actually exposed quite a number of our healthcare workers. And so we had patient 37, patient 69, and patient 34, patient 11. And so 4 were exposed. One of them was a doctor, and the doctor also actually exposed or transmitted the disease or the virus to another person. After that, because of the fact that we already had the first case and the transmission, we started to really take this very, very seriously, and we had to strengthen enforcement of healthcare worker protection and exposure. There was a rigorous contact tracing done of all exposed healthcare workers and a forced 14-day quarantine if they were exposed. So at this time, we already had some of our healthcare workers, a fellow of critical care, and some others who actually turned out to be positive because they started having fever. And so we had to quarantine, and eventually he has to be admitted. And all the ones that were exposed, because we were not as tedious and stringent in our care initially, had to be quarantined. And that's the time that the highest number of quarantined healthcare workers we had was 191, which had a serious implication as far as manpower was concerned, no? Because we had to send them home, we had to make sure that they were okay, but at the same time, we had to redeploy a lot of nurses and a lot of residents to man the emergency room. So with that, we started really repurposing our facility. We identified rooms that were going to be exclusive for COVID, and with strict protocols, manpower redeployment in the setting of nurse shortage, and revised shifting of patterns for nurses and the residents. So this was already beginning to become the new normal. No? And because of the fact that the cases that we had eventually were really the more severe kind, we started having the group practice model where the pulmonologists or the cardiologists or people of the same specialty actually decided that they are going to go group practice. And so there is now a TOCA, one pulmonologist would take care of one floor of COVID floor and would never go to the non-COVID floor. So the non-COVID floor were covered by pulmonologists that would take care of them. And these are usually the more senior ones or the more vulnerable. Care of the COVID wards, and the older ones took care of the non-COVID. And in a group practice model, it was no longer the private practice model where one doctor would take a look at his own personal patient. No? So this was a thing that had to happen. So this is now the graph that you see, a daily count of the suspect and confirmed cases of medical city based on tests done. And you can see that we started peaking. Initially, a lot of them were confirmed, no? Initially at the early part. And then at the latter part, we had more and more recoveries. And then we had some mortalities, no? Then eventually at the latter part, the last few weeks that we had here, first week of May, you can see that we have admissions, but you can see that we don't have any more mortalities, and we have now more recoveries. No? So the case fatality rate we have is about 7 or 18%, and the recovery rate is 62.24%, no, based on medical city admitted and monitored patient count from March to May 11. The medical city actually has been handling about 2 to 3% of the reported confirmed cases across the country. So it's quite significant, and apparently that's the reason why I guess the medical city has acquired the reputation that we are basically a COVID hospital. And that by itself also has a negative downside because of the fact that our patients would not have the courage to come to see us. No? So then we had to handle the manpower. because a lot of the healthcare workers were actually discriminated against, and they were actually refused admission in their dormitories. So they were forced to stay in the hospital, and it's a good thing that we had donors that would accommodate them with free food and accommodation in nearby as La Salle, the CCF, also the micro tent, and so La Salle, we were very happy for that, and then we started having a lot of donations, which actually is part and parcel, I think, of this COVID phenomenon. People sharing with the resources to be able to be of help to everyone. No? And so we now had one entry, one exit system, and we had to separate the COVIDs from the non-COVIDs. And then quickly, the medical group started to come up with COVID clinical pathway, establishing a pathway innovation of infection control, and then ongoing training of nurses and med techs. No? We also converted some of our rooms to negative pressure, conversion of regular rooms to negative pressure rooms, which also, of course, required expense to accommodate more COVID patients, because we started to extend our patients to the emergency room. And then we also had a fever clinic where patients who are otherwise just with fever, but probably not with COVID, but because of the fact that we were getting a little paranoid, we wanted to make sure that any patient with fever should still be seen elsewhere. And then we separated our emergency room, the previously pediatric emergency room, we converted that to the COVID response unit. And so now actually we ended up with 2 ER systems. But at that point, when we were peaking, both of them were actually handling COVID cases. No? So we had to transfer our pediatric emergency room to the 6th floor because we did not encounter any problem with the pediatric cases. Okay, now March 14, because of the fact that we were getting swamped and we were getting overwhelmed, we started communicating with the other medical directors of the private hospitals, the big hospitals here. And with that, we decided that we needed to take matters into our own hands because we did not feel the support of or DOH. It was very clear to us. And that's how we came out with an appeal in public. It was actually published in the Inquirer, the Alliance of Hospitals Appeals for a Unified Approach to the COVID-19 Pandemic. And we were asking for DOH accredited, assigned public hospital for the DOH. No? And that was eventually ended up with PGH and Lung Center of the Philippines and the Sanitarium, Tala Sanitarium. So the thing here is the communication that we established among ourselves. So we were no longer just dealing with our own problems. We were actually sharing, and we were also accommodating rooms for COVID when there is a spillover from our own emergency room. And then by then, we already started talking with the group of Mayor Vico Soto. He came to Medical City together with all the medical directors of the Pasig City hospitals. And we decided that we are going to collaborate and coordinate so that there's going to be like a hubs and spokes system where we take care of the most severe and the other hospitals can take care of the moderate. No? But eventually, Mayor Vico apparently realized that there was a need to actually assign a COVID hospital among the Pasig hospitals, and he chose the Child's Hope, the Pasig City Children's Hospital, which he converted and which we facilitated. We helped him put it up. He was able to buy 21 respirators. We were able to provide briefing to their group. The group there came to Medical City, and we shared best practice and all these things. No? So this was a good public-private partnership that actually I talked about with Rosette Vergere. When we reach a certain point that we could no longer handle it, we really need to come up with a disclaimer or an appeal to the public that we no longer can accept because we really were reaching a very overwhelming point. No? And so we released a Medical City memo that was taken positively. We thought it was going to be taken negatively. It was taken positively. And so we were able to get our staff to be to get some rest. No? It was about this time also that we started collaborating with Valenzuela, the Mayor Gatchalian, we had a MOA that we will be doing the tests for them. And so as far as the treatment is concerned, we use, of course, chloroquine and hydrochloroquine for mild to moderate. We also use lopinavir and ritonavir. This is a tablet combination. But we have used very sparingly tocilizumab for severe cases. And we don't use the convalescent plasma. We don't have that. But we have given mesenchymal stem cells from the umbilical cord blood coming from our own regenerative lab. And we would be reporting this very soon separately because it is something that we can be proud of. Now, in the critical care, other than what they're doing, there is an observation that mechanical ventilator might actually cause more damage. So they are now more geared towards really just intubating but not connecting to the mechanical ventilator and just giving high flow oxygenation. And we also have this pronation where patients are made to lie on their chest, because lying on their chest actually have an impact in terms of distribution of oxygen in the lungs. No? And we have seen that this apparently provides some relief and improvement clinically. So this is the medical intervention in the proning, self-proning and awake non-intubated COVID cases. And, this can be done among all of us who may not have the COVID, but there seems to be benefit when you sleep on your stomach. No? Later on, we had to make do with the fact that there's a lot of fear and people were not coming to our office, to our hospital. We created the lab on wheels, where we actually went to our non-COVID cases in their homes to be able to service them for their laboratory needs. And then the doctors themselves were having teleconsultation services to our patients who did not want to go to the medical city. And of course, the psychosocial support, we cannot underestimate the importance of the psychosocial report, the support, the mental health support. And we had at the head of our own psychiatry department, Dr. Mel Batar, who actually made sure that her team would give some debriefing to our residents and healthcare workers when they were beginning to have burnout. We also have this MANCON, where patients who are actually isolated in the different COVID wards, because of the fact that there are no visitors allowed, they can actually connect with their families at home. No? We also have some psychosocial support in terms of staff and patients, in terms of all the cards that are coming. Then we realized that even if things were getting better, there was a lot of fear. And the fear is not just patients, the fear is also the doctors. No? And there was really a need to kind of disabuse this thing about fear. And so we now are, at the moment, we are now trying to have a campaign that social distancing stays, you wear your mask, but beyond that, there is no need for people to really walk around in their hazmat suits and all their shields and everything. Because apparently it also scares a lot of people. No? So this is something that actually a lot of people appreciated. And one of the things that we realized was that there was a hunger for good news. Any good news, this is communication now, any good news would really have an impact, not only in terms of the patients that are actually in the rooms, but also actually the healthcare workers themselves. No? And so we actually launched the Code Joy. Code Joy is actually the complete opposite of Code Blue. Code Blue is when you call a code because somebody is dying and you have to intubate and you have to rush. Code Joy is when somebody is going to be discharged. And this one is really a hospital-wide initiative. Now, I would just like quickly. So just to report, in terms of the infections involving our healthcare workers, initially we had quite a lot in the first 2 weeks. No? So we had actually about 6% because we had a total of 600 healthcare workers that were tested, and most of them were, of course, asymptomatic, and 38 came out positive. No? So that's about 6%. No? But in the latter part, we had 250 asymptomatic healthcare workers that we tested when our laboratory was open, and only 5 turned out to be positive. So that's really a decline in terms of, that's around just about 2%. And it shows the fact that when you have health distancing, social distancing, and you have the masks, that's good enough. And then if you know how to don and doff your PPEs, you know how to handle all these fomites and all these things, knowledge and information is so important. So now at this time, we are trying to get patients to realize, and this now is for doctors. No? Tough times don't last, tough people do, because doctors now need to also be reminded. Now, this is now time to snap out of the fear and to come back to the hospital. And some of them, the neurosurgeons, for instance, they say the neurosurgeons of the medical city in the time of COVID, they never stopped. Indeed, they were all here, they were attending, and they were doing surgeries. No? So we now started with a safe zone for all patients by coming up with 2 different hospitals. It's a concept where 2 hospitals in one hospital, where we have a separate entrance, we have a separate exit, we have separate elevators, we have separate floors, and so they never get to see each other. No, so it is something that we have started about a week ago, and apparently it helps. And now people are becoming aware of what we have here, and people are coming back, as reflected by now our parking space. No? It used to be that's empty, but now we have a lot of cars coming back, and it's a good sign that people are, of course, aware that it is now safe to come back with social distancing and with the masks that we have. So I guess that's I would like to share that this is not just about the virus itself; it's also about the virus of fear that we have to actually surmount. Thank you.
Thank you, Dr. Jean. I am sure your insight about the need for leadership and communication in managing fear is really applicable, not just for hospitals, but for all levels of governance. And your institutional narrative of adaptation, evolution, and partnerships is really interesting and will have relevance beyond the pandemic, including the stigma and discrimination that you mentioned that resonates with the experiences of healthcare workers around the country. So now we move to our third speaker. We're mindful that the world that we have to live in now requires avoiding crowds and wearing masks anywhere we go. Mr. Ek touched on this earlier. But this reality is actually nothing new for people who are immunocompromised. To share how we can prevent COVID by applying the protective measures commonly practiced by cancer patients, we have Dr. Beatriz Trixie Tiangco. Dr. Trixie is director of the Medical City's Augusto Santiago Cancer Institute, and he's been very active in non-government organizations promoting the need for awareness and experiences of people living with immunocompromised states. So let's now hear from Dr. Trixie.
Thank you very much, Gideon, and thank you everyone for joining us today. My name is Beatriz Trixie Tiangco, and I'm a medical oncologist. And we have just heard from the chairman and the CEO of this hospital speaking about perspectives from the world outside, the economic point of view, and from the hospital, the perspective of the hospital, from our CEO. And I'm going to talk to you a little bit about the individual, what we can do, and what we can learn from the immunocompromised. And this is really addressed to Juan de la Cruz and Juana de la Cruz, especially those who are, as Eugene mentioned, still scared of the disease, especially perhaps the immunocompromised like the seniors or maybe those with diabetes or hypertensive, because they've always heard that they are more susceptible to COVID. So the title of this slide is Flattening the Curve Merely. What it does is really, it just really slows down the disease. the virus spread, and it really buys time for humanity to handle the disease. So we see here that in the past 2 months, everything we've done, like wearing masks and social distancing, really just slowed the disease, hopefully to the point where not just the healthcare system, but the entire Filipino community can handle the disease better. And so I'm going to talk a little bit about prevention. There's really two kinds of prevention. There's the primary prevention, which prevents one from being infected. So what we can do in order to primarily prevent us from getting the infection is we can wash hands frequently. And this means washing it under running water for 20 seconds, use soap and lather it up. Also, as you all know, social distancing, and that is 1 to 2 meters apart, especially while you're in quarantine. You want to stay alone if possible. Do not touch your face or areas frequently touched by the general public. For example, doorknobs or the handles in the stairs. You have to assume that the virus is everywhere. You also want to wear personal protective equipment, especially face masks. Other things that you might want to do is join ongoing studies on the prophylactic antiviral treatments and have yourself vaccinated against the virus. However, we still don't have any virus available, and the rumor has it that that might take maybe another year or so. Some scientists have thought about using the BCG vaccine. It might stimulate the T cells or the immune system of TB patients, but also maybe it might stimulate the T cells of our body, our antibodies to fight the COVID virus. So we shall see. Another kind of prevention is secondary prevention, which prevents the spread from an infected individual to other people. We have to be able to detect the virus while it is not yet symptomatic. In other words, we have to do mass screening, isolate the positive, and then do contact tracing. So that's the test, treat, and trace, the triple T's that we've heard over and over again in the past several weeks. What this does is it merely prevents the spread of the virus to others because, as was mentioned earlier, once you have it, its natural course will take place because there is no treatment. So prevention is key, and I like to remind everyone that even though healthcare workers are looked at as frontliners, that in truth, an individual person, you listening to me now, you are the frontliner. And these are preventive steps that can be done while you are at home, perhaps, or when you're ready to go back to work, or when you have to go back to work, even if you don't really want to yet and are a little bit scared. These are the preventive steps that can be done while you are not sick. You want to be able to control your comorbid illnesses, especially those with diabetes and high blood pressure. While at home, you do want to exercise regularly. You want to avoid stress, get enough sleep, eat well-balanced meals, maybe drink omega-3 and vitamin and mineral supplements, and drink at least 2 liters of water a day, especially nowadays where the heat can make you suffer heat stroke without you even knowing it. What will you do if you have symptoms, if you develop symptoms? First thing you should do is consult your family medicine or internal medicine doctor. We are now seeing more and more doctors do telemedicine or teleconsults, and I think that's a good thing, not allowing the patients to stay at home. You do want to get more rest, so if you start coughing, have a slight fever, have colds, drink higher dose of vitamin C and zinc. This is anecdotal, but still it's not going to harm you. Drink again 2 liters of water a day. Take your temperature 2 to 3 times a day, and take your Biogesic or BioFlu if your temperature is greater than 38 degrees, and take it 3 to 4 times a day as needed. You may also take mucolytic as needed so that your phlegm will loosen up and you will feel more comfortable. As we all know, preventive measures will sometimes fail. Even if we do our best to avoid the illness, some of us are going to get sick. And how do you decide if you need to be tested? By the way, earlier, our chairman mentioned that Gen Amplify, the locally available kit, was an antibody test. It is not. It is a PCR test. It tests if you have the virus. It doesn't test if you have the antibody. But this is actually the more important test to take in order for you to know if you have the virus, if you are sick with the virus, and are where you can take your oxygen. If it goes down to less than 95%, provided you were able to take your baseline and it was higher than 95 and you have no chronic lung disease. These are some of the signs that maybe it's time for you to go to the emergency room and have yourself tested and checked. So where do you go? Where do you go if you feel that you need to be checked or that you need to be taken care of in a hospital setting? And what happens after you get tested or swabbed? You're going to get advice from your doctor. In order for you to go to the emergency room, you don't really need a request, no? But sometimes it helps if you call your doctor in advance, and the doctor will be able to either give you a request through your phone or call up the emergency room and say, patient Juan de la Cruz is on his way, and please assist him so that he can be swabbed. Call your favorite hospital and ask if they have the PCR test available, and then go to your swab site. You will be assessed at the emergency room, and you will be advised whether you should be admitted while waiting for the swab result, or if you can go home, or if you should go to a quarantine center. Now, I'd like at this point to be able to put things a little bit in perspective. As I mentioned earlier, I am a medical oncologist and I've been in practice for over 20 years. And over this length of time, I have gotten to know cancer patients and how brave they really are in facing an illness like much of us now are facing, threats to our life, threats to our quality of life. And if you will look at the data that I shared here, and this is as of yesterday, the COVID data of 2020, there's a total of 11,350 total cases nationwide, 264 new cases, and 751 of our countrymen have died of COVID. If you look at the cancer data from 2015, of course, cancer has been around for a long time and people are aware that this happens, and that many times it also, you wake up one morning and you realize you have stage 4 cancer. But I'd also just like to share with you that the data for our country of 106 million people is that there are 141,000 new cancer cases every year, and 86,000 of these cancer patients actually pass away from the disease. So patients with cancer also have this threat, like this sword of Damocles hanging above them. So our new normal, those of us who don't have cancer, is not new and perhaps just normal for our cancer patients. And there are certain things that maybe we can learn from them. For the new normal, for non-cancer patients, is, for example, the COVID virus threatens to invade you and take over your life. Illness can hit suddenly out of nowhere, and upon diagnosis, it can already be acute and life-threatening. This is normal for cancer patients. Cancer has established itself inside you and threatens you. Cancer can hit suddenly, even in those without risk factors like smoking or drinking, and upon diagnosis, it can already be widely spread in stage 4 disease. For non-cancer patients like us in the COVID era, those with comorbid illness or aging immune system are at a higher risk for death from COVID. What we should do is wear a face mask at all times outside the house. We should wash our hands frequently, and we should exercise social distancing. That is true and has been true for all cancer patients. You see, cancer weakens the immune system, and its treatment weakens the immune system even further for a period of time. So the risk of death from any infection is always there, especially those receiving high-dose chemotherapy or high-dose radiation. What do they do when they have chemotherapy or even just going out in public, even if they're in between treatments? They wear face masks at all times outside the house. They wash their hands frequently. They eat only well-cooked food, and they avoid crowded areas. So this is the advice that we have been giving our cancer patients for many years now. So for COVID patients or for those under the threat of COVID, there is no known treatment, and experimental treatments are given at your own risk. These can be very expensive and can actually go up to maybe $1 million, but sometimes really you cannot put a price tag on your life. So people are willing to spend a lot if only it will give them a chance of being saved. But however, side effects of these medicines can also kill or can cause other illnesses, and new treatment may not work even if they are very expensive. This is something that is the reality for patients with cancer, especially stage 4 cancer. It's incurable, many but not all, and new treatments are attempted to be able to extend the life of patients. However, this may not work either. Side effects can also kill, and we all know that chemotherapy really is toxic. So we are now moving towards less toxic but equally effective medicine. But these are also very expensive, and the new treatment may not work, even if these are costly. For non-cancer patients who are at risk for COVID, even if you test negative twice, and are declared COVID-free, you can test positive again in the future. Now, these are anecdotal stories that we have heard. The patients have been sent home with 2 negative results and then later on test positive again. Clearly, there's a lot that we do not yet understand about the immune response of our body to COVID. So also with cancer patients, even if our patients with cancer are already cured and these patients no longer have any masses in their body, the cancer can come back, especially within the first 5 years of illness. So imagine having to handle that uncertainty, but really many of our cancer patients, admirably, are able to live with this uncertainty, and so can all of us. COVID will unlikely be a thing of the past, so we're going to have to learn to live with it. And what can we learn from our cancer patient? Once a cancer patient, always a cancer patient. Luckily, many of them nowadays can also be a survivor, a cancer survivor. However, I can tell you based on the patients I've met, and I admire them all very much, life is never the same again. And again, you're going to have to trust me on this. It's never the same, but many times it's actually better. So what tips can we learn from our cancer patients on how to live a full life, even while it is under threat? First, accept that your health is under threat. The easier and the faster you accept that, the better. Understand the situation and learn how you can avoid getting sick with COVID and how to live among people who have it and may give it to you. Let go of things that you enjoyed but now could threaten your life. For example, Sunday mass or family gatherings, fine dining, vacations abroad. Try to define your comfort zone and work or live well within this safe zone. Join clinical trials to help gather evidence for effective COVID treatments, and make decisions based on facts, not on fear. And I know Eugene has mentioned this over and over again, but let this be my last slide. Nothing in life is to be feared. It's only to be understood. Now is the time to understand more so that we may fear less. And let's thank Marie Curie, who won the Nobel Prize for Physics and Chemistry long ago, but certainly this is still very relevant today. And with that, I thank you.
Thank you so much, Dr. Trixie, for bringing our discussion from the broader economy and the hospital to the level of the individual and drawing parallels of the clinical and social experiences of cancer patients with those of COVID-19 and all of us today. So throughout this forum, our speakers have used statistics and clinical experience to make recommendations and offer insights about the pandemic. But what about the cultural dimensions of COVID-19? What can we say about the police model of public health that is seemingly prioritized today over some of the recommendations that we've heard so far in this forum? The HIV activists in the country and one of the founding members of the Philippine National AIDS Council. Let us now hear from Dr. Michael Tan.
Thank you, Gideon. I'm looking for my presentation. Is it on the screen now? It is on the screen. Okay. I'm going to start off with an apology. This computer, I forgot that this computer has problems with PowerPoint, so it can't go full screen. But you are able to read it. It's just that you might be distracted at the side. But you can read the slide, right, in the center. So the title of my presentation is Changing Mindsets, the choice between top-down coercion, which is the predominant mode right now, or working towards partnerships for the common good. Oh no, something went wrong, no? It's not the right PowerPoint. Sorry, Gideon, what you see there now?
I'm seeing the first slide, the changing mindsets.
Okay.
So it is the PowerPoint.
I'm sorry, let me... Something's wrong here. Our worst fears. I apologize for this. I need to... It's not coming out there. Okay. So do you see it, changing mindsets right now?
Yes.
Okay, let's hope it goes. And now objectives? Okay, we're fine. Moment of panic. No? What do we mean by changing mindsets? And I thought we should define that first. We're talking about a mindset that recognizes the urgency of the pandemic, no? And that a delay of a day or two in the interventions can mean a few hundred deaths. No? This includes whether to continue with the quarantine. All of these are really life and death decisions. It's a mindset that must be based, of course, we agree on evolving, because this disease is so new, but an evolving scientific understanding of medical facts. And I hope to impress people with the need to recognize the social realities of the pandemic. And finally, when we talk about changing mindsets, we want the mindset to be converted into a shared conviction that brings around social action and solidarity. Before the lockdown, I think we can agree that there was growing anxiety, but generally people were still complacent. And President Duterte's announcement of a lockdown, which was done a few days before the lockdown itself, it spurred some panic, but I've always seen it as panic in slow motion. You didn't see, I mean, people rushed to the supermarkets, but you didn't see the kind of hoarding that you would see in many other countries or in the Philippines when we had crisis before. But the term lockdown elicited negative reactions, no? And President Duterte himself backed down, and they moved to the term community quarantine. So there are people around him who seem to know the power of language, and they used community quarantine, which I think was a bit better. But when it was finally declared, I can only use the phrase shock and awe. No? It was, people were, none of us, I can imagine, expected to see what happened. You had the checkpoints. I think what was the most shocking was the ban on public transport, because the people who were still at work could not get to their work now. And of course, many people thrown out of their jobs. Maybe that was worse than the ban on public transport. TV interviews that were still being conducted. Many people talked about losing their jobs. We saw also in the first week that there were problems because it didn't seem clear. There were general guidelines, but the implementation was not clear. And this is an actual headline: different checkpoints, different rules. And in fact, different barangays had different checkpoints and different rules. Cities each had their own. And we know that by the end of the first week, the full impact was coming on amidst the chaos and the confusion. But the full impact hit hardest at the low and middle income families. Much more, of course, with the low income families. And then as we went into week 2, we began to see a lot of doomsday scenarios. Everyone suddenly wanted to do mathematical models, estimates that ran as high as 200,000 plus cases within a few weeks. That was the estimate. That was the prediction. And the rumor mills, of course, went full blast with in neighborhoods about some, here in UP, when they wanted to send me something, I said, don't send it by ambulance because there'll be rumors right away that I had died or something. And the language that was being used did not help because it was a language of surveillance. An unfortunate choice, people under investigation, which they replaced later on with the term suspects. No? They might as well have called confirmed cases convicted cases. No? It was just two words. Words mean something, and they have to review that. The community quarantine itself evolved into enhanced quarantine. And finally, local government executives decided let's use the term lockdown. And lockdown itself evolved, and you had things like total lockdowns, which really sounded horrible, but was actually implemented in an even more horrible way. And I'm going to talk about that in a while. We saw too with time that the coercive power of the state and the police and military presence became stronger. By day 14, March 20th, I thought that I should show some photographs here, and maybe after today's session, I'd like to produce something from day 1 up to we are now in day 16. But day 14, March 28th, just to show what was going on. This is a crowd outside Mambalacat City Public Market, one of the many places where officials were really looking for ways to implement physical distancing, but they were doing it with things like staggering market hours, which resulted actually in bigger crowds. You can see this particular photograph. Physical distancing is impossible here when people crowd in. We had something similar a few days later in Blumentritt in Manila. The local government executives really should be learning from each other, but they don't seem to exchange enough. Day 18, April 1, the economic crunch. We tend to underestimate how bad this is happening. The iron fist tactics people were beginning to resent this. No, April 1, there was a rally, City San Roque in Quezon City. Very small rally, but they were arrested. And President Duterte responded, as you know, with threats, to shoot violators. We know he talks that way, but it's always dangerous when he does that. And this is a picture from April 3, just to show what people in Sitio San Roque were going through. This was taken on April 3. This is life in San Roque. Can you talk about physical distancing in a place like this? And we know the situation is that way in many parts of our cities. So April 1 was their rally, and then there was the threat from President Duterte. And actually, a few days later, I don't have a picture for that, a 63-year-old man was shot to death in Nasipit. People forget this. That was the first fatality. He was not wearing a mask, and he was accosted, and he was drunk. And when he refused to comply, he was shot to death. Even worse, on April 21, day 45, we know that a former soldier was shot to death by the police. He was standing in front of his house, drinking soft drinks and smoking, and he was asked to go in. And people told the police that the man had mental problems. It turned out he had post-traumatic stress syndrome from his military service, and had not been taking his medicine. I thought this speaks of the problems we have. So many people who need their maintenance medicines from everything from hypertension to mental health to tuberculosis and even to anti-HIV, may have problems because of the lack of public transport, and they're not having jobs. You need money even for just to be able to go, even if the drugs are free. So this man was killed not just by the bullets, but really by the lack of social safety nets in our whole quarantine. Okay. Day 52, May 5. In fairness, after that military man was shot down, we have not heard of new cases. I think the police and the military are really controlling themselves now. But you still see a very heavy presence of the police, and this was exemplified on May 5 when a barangay in Tondo was put on total lockdown. And they brought in 1,400 policemen. I think that's overkill, including 200 special forces, the SAF. 200 people were rounded up for violating the lock-in. The lock-in was now being interpreted as staying inside your house. I actually saw video footage people could not even sit in front of their homes. They would be arrested, and the police made it clear they would have criminal records. And then it turns out this lock-in was declared not because of new COVID cases, but because they were going to implement mass testing. Now try to imagine that. How are people going to look at mass testing now? They're going to see it as a military affair. They were going to see it as a way of hunting down criminals, given that you use words like suspect. It was a very, very bad move. It created bad moods. And I don't know how we can repair that. And today we are in day 60. The public is now reacting to many with relief because their areas will no longer be under quarantine. Manila, Laguna, and Cebu, of course, will remain under enhanced quarantine. I love the way we take up new terms. Quezon City has declared that several barangays will be now under special concern lockdown. Now, what are the outcomes here? I have no doubts that quarantine and your non-pharmaceutical interventions like the mask, Eki has talked about that, physical distancing, hand washing, they've made a difference. No one's going to debate that. But the numbers of infected are also relatively low, but we know the testing needs to be ramped up. And there are very disturbing clusters in some communities. I will just give you the numbers, not the community names. I just saw a report where there were 120 cases in one barangay. Infections are happening. The poor are not immune, as some people want to talk about it. It is raging through our urban poor communities. The prevention measures, other than lockdown, are being implemented haphazardly, sometimes even violated by the very authorities. Sometimes good intentions, like the thing about the markets, but creating crowds, which we don't want. And the infodemic, of course, is not just medical, it is also political. Fake news goes around, spread by political opponents. We have to look at that also. And we know we continue to face many constraints, the grinding poverty, the loss of jobs. And it's affecting not just the poor, but the middle class. And the gutom narrative is growing. People always saying na mamamatay kami dito, hindi sa virus, kundi sa gutom. I've been asking social weather stations when they will conduct a new survey on hunger. I'm sure the numbers would have shot up. We know that the housing shortage is such a problem, huge congested urban poor settlements. Barangay Bagong Silang in Caloocan has 245,000 people living in 524 hectares. I cannot imagine physical distancing being implemented in a place like that. The constraint too is low levels of health literacy even among the upper class. Scare tactics are there. Government did this so that people would comply, but I think they overdid this. And now our risk perceptions have gone out of proportion. We fear our neighbors, but we don't wear our masks properly. We don't hand wash. We don't observe physical distancing. A lot more needs to be done to set people's priorities. Have the fear, but it must be contextualized. This is a picture from Zabarte, Caloocan. You probably can't see too clearly. In front of Pure Gold, there is a sign saying what needs to be done. And they also put there, take vitamins rich in vitamin C and zinc. That's the exact wording. And next door was a drugstore, no stocks. They had many multivitamin preparations for which they ran out. My point here is that people see the other things there, like taking vitamins. Dr. Trixie just talked about some of them. People on their own are taking some of these interventions, not always properly. They're also prone to a lot of exaggerated claims. And then, of course, hanging at the background constantly to justify police tactics is the pasaway narrative, that ang Pilipino daw ay pasaway. You heard Harry Roque saying that we are so hopelessly pasaway. What are we going to do here? And I use this picture. This is a place that is under lockdown, and you see people on a Sunday actually went out to the beach. This is not in the Philippines. This is in Southern California in the United States. Sino ba ang pasaway? We might want to look at our own situation as well. We tend to look at the poor as pasaway, but we know that it cuts across classes. And pasaway is not, in the way people want to talk about it, simply hard-headedness. No, pasaway is often one of despair. In America, they go out to the beach because they want to. Here, pasaway means trying to get out of a barangay that's locked in so that they can get medicines and groceries. No, I actually talked with a man who was locked in because he could not get a quarantine pass because he was a transient. So every day he would look for gaps in barbed wire around the barangay so that he could go out. Let's not forget the trust factor as well. The Philippines has one of the lowest levels of trust in the world. No? In the last World Values Survey in 2014 showed that only 2.8% of Filipinos agree with this statement. Most people can be trusted. I don't know how many of you out there agree with that statement. And if you listen to people, those trust levels are now threatened under the quarantine. People talk about kurakot, palakasan, gulpi, sinisigawan, even here in UP, and more. Can it be different? I feel it can. UP Diliman, you know that we are number one pasaway in the nation of pasaways. I did want to share very quickly our experiences. During the quarantine, we had to handle 245 stranded dorm students, 800 students who are boarding near the campus, 300 stranded construction workers abandoned by their employers, some with families, 80 stranded national minority students, evacuees from Mindanao, staff who said they wanted to stay in, food service workers so they could cook for the dorms, security guards, and we have guest health workers from the Lung Center. And that's over and above the regular residents, that number from 30,000 to 70,000. What we did here was we urged them to stay put in their dorms, in their lodgings. Borrowing the American term shelter in place. We provided food prepared by our own food service and the overwhelming donations from alumni. Construction workers also got their share, and they on their own followed our recommendation to divide themselves into teams and to follow the rule of the designated person going out to buy groceries and supplies. They had no quarantine pass as well, but we vouched for them. But my point here is that pakiusap is important. Pakiusap is give and take. We provided psychosocial support. They're lucky that they were in UP Diliman with a green environment. And coming out of all these experiences, we took the bold move of inaugurating a Kanlungang Palma, that's AS, as a quarantine center. And I know many schools are coming up with similar arrangements. But note again, as a social scientist, the importance of words. I said, let's not use quarantine center. Let's talk about kanlungan, hindi kulungan, which is what quarantine is beginning to emerge as the case. We all need in UP and outside to strengthen the information campaigns and our education campaigns. There's a difference between the two. I just had to give this as an example. UP was about to print educational materials with this picture. You can guess, I had to stop it. You're not supposed to touch your mask, and our educational materials. Something as simple as that we had to follow. We had to keep track. We have had rumor control. We monitor social media because rumors are really very destructive. Community kwento-kwento with appropriate responses. We don't always refute the social media posts unless it becomes rampant. All of this really should be part of our responses as we try to change people's mindsets. I'm glad to say what was the outcome. In the areas we handled, we've had only one security guard who's now being tested. We don't know yet if he's positive or not. And he was not a resident. Maybe it would have been better if he was inside UP Diliman. He was going home to a nearby barangay where he might have gotten the infection. Outside of the areas where we have intervened directly, still within the UP campus, there have been 2 cases during the first 2 weeks and no new cases since then. I think what's happened is that we have a strong sense of working together for the common good. People grumbled, why do we have to put up a quarantine center? But generally, people do appreciate that our approach is different and effective. Some parents actually said they preferred having their children stay in our dorms rather than going home. I'm sure that was so they didn't have to take care of them. It could be UP's responsibility. Let me end now with recommendations. Coming out of different experiences, I did want to say we have to stop the police state approach. We have to stop the locking people inside their houses, not even allowing them to stay outside right in front of the house. We need to create safe outdoor spaces. It is more scientific than putting people, especially in slum areas, inside their homes without fresh air, without sunlight. We need psychosocial support with special advocacy for women, children, the elderly, people with disabilities. One TV network gave me the video of this man who beat up his partner and the daughter. It was just so heartbreaking. And I'm sure many of these things are happening right now, especially in barangays that are locked in. We have to ramp up the testing and use the figures. If the clusters should be publicized. I thought about that when Dr. Jean was showing one of the clusters there. We have to remind people, like in Mindanao, a cockfighting derby resulted in 11 deaths. That was not publicized enough. We have to talk about what carelessness can do and how COVID spreads. The clusters have to be shown. And we have to transform our language, stop using lockdowns, maybe move away from quarantines to shelters, move away from fear tactics to what people can do, move away from order ito ni Kapitan to pakiusap. And of course, the words need sincerity. We need to do social science research, which Gideon and I hope to do, to identify the environments of risk. What are people thinking? What are people doing? We need to build partnerships, and I'm very proud that I'm part of the medical city with the public-private partnership. Barangays must learn to work together and not aggravate what's happening. You have barangays pitted against barangays now. And of course, the class divide between the rich and the poor. We have to walk the talk. And we have too many songs, I think, about bayanihan. Let's stop singing. Well, continue with the singing, but we should start doing more things. And people have to see results converted into action. And we need more models for compassion. Pakikipagkapwa and pagmamalasakit. I feel Pasig City is a model. A compassionate mayor who dared to defy authority. Nearly got into trouble for that. We need to hear these counter narratives and models. And as we move into a new normal, that picture there is so typical. The worst mistake is to think that the new normal should be like the old abnormal. Let's prepare now for progressive recovery. At Medical City, we believe in short confinements, progressive recovery that addresses underlying conditions that have made lockdown so difficult. And I end with an appeal that really, to build partnerships, we have to empower people more for self and community care, self-care and community care. Maraming salamat sa inyong lahat.
Thank you, Sir Mike, for revisiting the pandemic's chronology from an anthropological perspective, foregrounding people's experiences, emphasizing the role of language, interrogating the coercive and misguided measures, referencing the structural violence that has led to disparities, and also underscoring the need for safe outdoor spaces and counter narratives, among other recommendations. I'd like to, at this point, also thank everyone for staying with us. Questions have been coming in as our speakers were presenting. So please, we'd like to hear more of your questions. But now let us start with a open forum. I will now start with the first question, this time for Mr. Eki. Sir Eki, with all the different kinds of tracking systems that you mentioned, which one do you think is best for the Philippines? And including, is the Thailand model good? So can you please explain more about tracking systems?
Unmute.
Maybe I'll move on first to the second question. Okay, Sir Eki, go.
Okay, as you can see from Thailand, it's a very cooperative culture. We have 2 deaths from the last two new cases from yesterday. I think the Thai are able to answer the question: how many people have moved away from community quarantine and be able to go home? To be able to answer that question, you need to know how many community quarantine facilities you have, how many beds you have in that area. In the Philippines right now, it looks like we have enough capacity for our hospitals, but we don't know how much capacity we have for our community quarantine facilities. If we have 10,000 active cases, 20% may show up in hospitals, but you have to address the issue of 8,000 potential mild COVID sick people. Where are you going to put them? And if we're able to answer that question, if we're able to know where we put them, if we're able to know that we can send certain people home, if we're able to track them, then I'm comfortable that we have enough capacity to handle the healthcare system.
Thank you, Mr. Eki. Just now that you're there also, can I also quickly ask a question from one of our audience about antibody tests? Can you also talk about the current experience now in terms of reliability of these tests?
There's a lot of talk about using antibody tests. So the PCR test is to tell you whether you have the disease. The antibodies test is to tell you whether you've had the disease. Antibodies come out around 2/3 of the way into the disease, the 14-day period. Therefore, you can't, if you put a test to somebody, 2/3 of the time you'll probably get a false negative, meaning the guy may say, you don't have it when you actually have it. So it's not as reliable as you want. The test that we are hoping to bank on is the latest PCR test, which is where you have only 10% false negatives, meaning it says you're negative, you don't have it, and only 10% of the time you may have it, because on that count you get the tracing of the virus earlier, maybe day 2 or day 3 rather than day 5, which is currently what you see today.
Thank you, sir, for the responses. Now, we also have a question this one is for Dr. Jean. I'd like to quote: in the public-private partnership, what is the benefit to the public healthcare system, which already operates beyond its capacity at baseline? In being converted to COVID hospitals, patients from these charity hospitals become displaced and will be unlikely to afford services in private hospitals. The poorly developed public health system suffers even more in this pandemic. Can we hear from Dr. Jean about this question?
I can cite to you what happened when we did the Pasig City Children's Hospital. It's a new building, and Mayor Vico decided to convert it into a COVID hospital so that all the pediatricians were actually moved to the other hospitals, and it was now being run by internal medicine and family medicine people. And he had apparently the money to buy ventilators. No? So it is a collaboration between Medical City and the hospital in terms of expertise, in terms of best practices, in terms of our critical care. We are able to collaborate with them. And the agreement is that if they cannot handle the severe cases, then we actually either we accept that in Medical City, or we actually provide them the expertise in terms of sending some of our young critical care specialists to the hospital. So it's a collaboration, and the good thing there is that it is at least it's covered by PhilHealth. There is not only in terms of the traffic and the triaging, it's also there is a sharing of best practices, and it actually is an occasion for Pasig public hospitals to be able to learn the way we do things. As a matter of fact, even before this, when Mayor Vico started his tenure sometime in August, September, we already started meeting in terms of the hub and spokes, in terms of community medicine at the level of the barangay centers are being handled by his own health center doctors. And so we are actually sending our residents there to provide support. We are also trying to actually send our operations managers there and our nurse managers there to see what we can do in terms of improving the system. So it's a systemic thing that we are trying to help. And for secondary cases, if it cannot be handled by the barangay health centers, they are actually sent to the Pasig City hospitals, no? Pasig City General Hospital or Pasig City other hospitals there. Then when it becomes really worse, then we provide the tertiary care. So it's a nice collaboration, and there's also a sharing of expertise.
Thank you, Doc Jean, for your response. Let's now move on to another question. I think Doc Trixie focused on the individual experience and also mentioned a lot about face masks, including those worn by cancer patients. Doc Trixie, can you talk a bit more about face masks in terms of which kinds of face masks are actually effective? And also, do you have any comment as to why the public health authorities changed their recommendation from not needing to wear it and now they're saying that you need to wear it in public?
I think you're talking mainly about, in the beginning, they thought it was droplets. And I think even up to the level of the World Health Organization, they were not sure, how it was being transmitted. So then they realized it's aerosolized. And so it's the masks that really are necessary, absolutely necessary. We know that already. And remember the purpose of having a mask is in order for you not to get it, right? And so if that is the reason why you're wearing a mask, then mask like this is a surgical mask. This is good enough for you to go out of your house and go out to the palengke, for example. There are N95 masks wherein 95% of the particles will not hit you. And these are the ones with our form that are white. And those are for people who enter the hospitals and who take care of patients who are sick. And then there are those that look like biohazard masks, and those are for the surgeons. If they are going to intubate or are going to be directly in the path of the breath of someone with COVID, and then these are the things that's the kind of mask that those doctors should wear. But for going out of the house, this will do. Even the cloth mask. Remember, it's just to remind you not to be exposed to the environment.
Thank you, Dr. Trixie, for explaining those points. So, today on Twitter, we see people expressing outrage about how a police general basically violated the supposed physical distancing through this birthday party. And we've heard Sir Mike talk about the police model of public health. So I'd like to ask Dr. Tan about the impact of people, including the urban poor, seeing these violations being done by people in authority. So what will be the impact on them on seeing these kinds of violations?
I think that's from eating popcorn. Don't worry. So the coughing was. The picture that was shown, was it by Dr. Jean or Dr. Eki? Someone blowing the birthday cake.
Yeah.
That, of course, is the more dramatic one. But again, for the man and woman on the street, they see the inconsistency and the biased treatment every day in many ways. No, like checkpoints. No, the worst thing to happen is if you're going by foot, because that's where they check your work papers, they do the thermal scan and everything. If you're on a motorcycle, they're a bit more lenient, but they still stop you. If you're in a car, they just look at whether you have a quarantine pass or not, and you can breeze through. It doesn't matter how many people are inside. You see it in checkpoints, different directions. I've seen so many examples. The most dramatic is the one between Caloocan and Quezon City. To go into Caloocan, there's hardly anything that's checked there. But to go into Quezon City, there's a long line because they're asking what they're going to be doing in Quezon City. And it is a class divide. Because if you go into Caloocan, that's a poorer city, and they don't care as much. The They don't even have people manning the checkpoint. But going into Quezon City, I mean, that's a richer, and they're stricter there. You see it also within towns, between barangays. Going into a rich barangay in San Juan, they disinfect your tires. And then if you're leaving that barangay to go into the next one, which is a poor one, again, they just let you go. So I'm sure people are looking, the poor are looking and looking at the double treatment. Let's not forget too, the arrogance. That's the most horrible one. We had an SSB, that's our security brigade, who was shouted. There was someone who was biking around the campus, and when the SSB tried to stop him, biking demands a separate set of rules. We don't talk about that too, but sinigawan siya. So sinigawan is a very common term. Sinigawan ako. This is and there's something very symbolic about being shouted on to comply. It's not just the shouting. Medically speaking, shouting is more dangerous than pakiusap. Shouting has more droplets when you think about it. So you're talking about safeguarding people's health, but the mere act of shouting is itself already problematic. Okay.
Can
you.
I
Yes,
add
please.
Yes,
Please, Doc G.
I actually forwarded to Mayor Vico an article, I think from The Economist, about the fact that when you're dealing with developing countries where there is it's impossible to actually implement social distancing. People like in San Roque, as shown by Dr. Mike, where people really live so close together. These are people who need to go out to work on a daily, no work, no pay. And so they really have to go and they need to work. And they work in places where manual labor really cannot prevent them from being, close to one another. And so that has an impact, because while we say that if you're old and if you're sick, you stay home, these young people actually need to get out and to start finding work for their families. And so that's precisely why this is not being taken care of. When we talk about social distancing, we're assuming that people have all the space to live in. But a lot of these Filipinos are living in those places where it's impossible for social distancing. And that's precisely why nobody seems to be taking care of that. And we just keep on saying social distancing, when in fact that's impossible to achieve. So I think nothing less than just basically wearing a mask. And even the mask, these people cannot afford to wear the kind of mask that we wear. They just have to have their bandana or whatever. These things are not being addressed. I think Dr. Mike Tan the point there is really somebody has to be taking care of this and taking a look at this. Now, at the checkpoints, it's the military. And the military mindset is really whatever is ordered us, we obey. We don't think, we obey. We follow the rules and nobody can even explain. And so you see in the news, in the pictures, that people are actually arguing and fighting with these policemen or these military people. And, it can actually go to up to the extent of violence and being shut up, because these military people are just supposed to follow the rules. They don't have to think. And that one is not being addressed as well.
Thank you, Doc Jean, for contributing to the discussion. And now, I think I have this final question for all of our speakers. I'd like to hear from all of you in terms of sharing your brief thoughts about recommendations after, because now we've heard the announcement about the ECQ, but what are your recommendations with the ECQ after this new round of extension? What can be done to improve? What can be changed? So very briefly, who wants to go first? Maybe we'll start with Sir Eki. Okay, Dr. Rixie, please.
While our chairman unmutes his mic, I will give my recommendations. I think we've flattened the curve in the past 2 months. as flat as it can get using quarantine. So I think maybe there are other ways to flatten that curve, perhaps, but we've already maximized the benefit from being on quarantine. And so I agree with Dr. Eugene that now we understand the virus, but we still need to be able to understand Filipinos, Philippine society, the Filipino psyche. And we have to ask ourselves, who's going to pay for that test? And who's going to feed them? So these are things that really still need to be now focused on. We've learned enough about the virus. Now let's learn what we can do in order for us to be able to end lockdown safely. I also think one last thing, that let's end the quarantine slowly. I think what the IATF, which I think has done a good job, is doing, is slowly doing it. Maybe start last na lang yung mga hotspots, pero at some point that quarantine has to end. Thank you.
Thank you, Dr. Ixie. Dr. Jean,
Yeah,
can you
well,
offer some?
there has to be an end to this, because I think more than just flattening the curve and really trying to unburden the hospital system, I think we have learned a lot during the last 5 months, actually. And so now people are aware how it is transmitted, and so they have to be very careful. I think it's not going to be the same way as it was before. And now with the social distancing among those who have the space and the masks, plus the fact that the testing has been ramped up, and then there are now actually a lot of facilities, the quarantine facilities, the PICC and all these other things. Then we do the testing. Then we slowly open, because a lot of other things can happen if we continue to actually cause all these checkpoints and these things. There's going to be fatigue as well with our donors. Like, for instance, quite a number of our healthcare workers are staying in the CCF and in the La Salle and in Metro 10. And I'm not so sure whether they can sustain us for a longer time. And those checkpoints have to disappear, because people need to go home and really need to get back to normal as possible. So it is not just about the viral transmission. I think it has a lot to do with the economics part of it as well, because health and economics have to go hand in hand.
Thank you, Doc Jean.
Yeah.
And now, Sir Eki.
I think. Sorry, I've been. It's been going in and out. But we have to remember that this virus is infectious, but not quite deadly. Unlike SARS or MERS, where you had 8% or 30% to 50% fatality rates. This is fatality, okay, across the whole population. The estimate is this could be a 0.06 to 0.2% fatality rate. And you're seeing it some countries where the health systems have held up pretty well. This is different from the case fatality rate, as opposed to the population fatality rate. We're only seeing case fatality rate, which is the tip of the iceberg. But remember, there are a lot of people who are asymptomatic, at least 50%, in addition to the guys that asymptomatic, in addition to the guys who show symptoms. Therefore, it behooves us to make sure that if it's not fatal for most people, and we have a very young population, if we make sure the community quarantining facilities are there, if we make sure that the laboratories can process and the test kits are there, and we're almost there. I estimate we don't need 30,000 kits per day. Maybe 12,000 might do within the next month. We're already at 6,000. So we might be close. We just have to count how many beds we have beyond Rizal Memorial Coliseum into the LGUs, and we can get there. So the big issue is going to be transport, okay? And transporting from people from homes. And that's why I keep on emphasizing the mask. So you were in New York, a lot of the infection was because the subway was kept open. But the subway guys in New York weren't told to wear masks. So let's see our guys wear masks, okay? They get temperature checked before they go into our subway system. They don't talk. If they don't talk, then the saliva doesn't spread. Now you can transport more. I walk around to the different markets in Caloocan. I see what's in Quezon City. people are up and about. Maybe what we have to do is to just have to encourage people to make sure that they cover their noses with their masks and not just their mouths, that they don't put them down. That if they want to get a respite, they go somewhere away, they stay for a couple of minutes, and they come back. This can be a simple solution. It's something that's not Western. It's something that was not WHO endorsed. It's not something that was practiced by the US, but it's been effective for Asian countries. So between that and are being more, I don't, I'm the military guys, like the frontline workers, have experienced 10% COVID exposure. So they're at risk too. I also noticed that the military are at the invitation, at the beck and call also of the LGU system. So the LGU can handle the issues in a different way, in a different manner. I think the military will also follow. So a lot of it is really down on the ground, how the barangays, how the municipalities and the cities can handle their populations by giving them the appropriate services. So if you show respect, respect will be shown back to you. So just within the last week, our remittance company distributed 300,000 allowances together with the city of Caloocan to barangays. And so that's a lot of distribution to do. But we sent out text in advance. We scheduled people to come in. They waited only 15 to 20 minutes. The teachers and the barangays were supportive. We worked together as one team. And there were lots of mayor compliments in terms of the way it was handled. And we can do this if at least we plan it that way across all our public and private initiatives.
Thank you, sir, for those recommendations. And finally, let's hear from Dr. Tan. Sir Mike.
I think the greatest fear right now is as we leave quarantine that the other countries are showing you can just spike again. South Korea, simply because the bars were open, they got a spike there. And sadly, we're going to see a lot of this in the United States because Trump just refuses to come to terms with reality. And they will show us what happens when you're careless with these return to normalcy. I gave my recommendations, but I think everything boils down to, it's not just a police model versus, and it's a matter of building trust. We have to, the reason the authorities are so hard on people is because they don't trust people. They have to learn to trust people that that they will comply if they understand what's behind that. You will see, I think the masks are very good examples. It's just so amazing how people are improvising. I don't know if you can see it there. I got this yesterday. Someone had created a hat with a piece of plastic. And I said, why are you producing this? He said, walang trabaho. But it's a cottage industry. You see masks being sold in sidewalks these days. Everyone's making masks of their own. Even face shields are improvised. You can buy a face shield now for 65 pesos. It's amazing. And you can reuse that. People will look for ways, hahanap ng paraan. That's a very common Filipino expression. On the other hand, we do need to build greater trust. People need to trust government more. The government has very low credibility, and that's going to be tougher. But as was mentioned by Doc Jean, you show respect for people, they will respect you. It has to be reciprocated. We will need to sustain a lot of these non-pharmaceutical interventions, the masks and all this. And it will work. The reason Japan used masks, they brought out their masks right away. And I read that this goes back to the flu epidemic of 1918. It was something that became part of their culture, and they never gave up on it. They see the use of masks, even with colds, as part of their courtesy. It's being considerate of others. I think we will move in that direction. I would like to think masks will not disappear from our heart today. But let's trust people some more. And we social scientists will try to bring out some of these other cultural nuances to be able to move forward. That's all I can say for now. Thank you.
Thank you, Sir Mike. And thank you to everyone, our speakers, our audience, the organizers. This is really an ongoing conversation. And I do hope that as we come to a close, we can continue asking questions and learning from each other's experiences. So on behalf of the Medical City, the Philippine Daily Inquirer, and Inquirer.net, this is Gideon Lasco thanking all of you for taking the time to be with us this afternoon. Have a nice day.
Thank you. Thank you.
Thank you.